Welcome everyone to today's webinar, CIO Perspectives, the Future of Virtual Care on a Cost-Neutral Basis. I'm thrilled to hand it off to Ed Marks, CEO of Marks Advisory, to moderate today's panel discussion.
Hey, it's Ed Marks here. Super excited about this webinar because this is a topic I think every one of us can relate to and probably deals with on a regular basis, and that's the future of virtual care on a cost-neutral basis. So certainly the cost-neutral basis is something that we're always dealing with in terms of being good financial stewards within our organization. And of course, virtual care is pretty much where we are and where we are headed more and more. So how do you do that on a cost-neutral basis? So the perfect guests that I have to tackle that difficult conundrum are with me today. And so I'm going to ask each of them to introduce themselves and tell you one thing unique about their organization and one unique thing about themselves. So we'll start with Brian.
Thanks, Ed. Brian Sterud. I'm the Chief Information Officer here at Faith Regional Health Services. We're located in Norfolk, Nebraska, a regional health system with employed multi-specialty practices as well. I'd say one interesting thing about our hospital is we're a 5-star hospital, so I love that, and we remind people of that whenever we can. That's always a great thing and indicative of the care that we provide. And one interesting thing about me is that, so I have 2 daughters. They're 20 and 16. When my 16-year-old was born, I weighed 100 pounds more than I weigh today.
Wow, Brian, that's amazing. Congratulations.
Thanks.
That's very cool. How about you, Inder?
Sure. Hi. Thanks, Ed. For all, I am Inder Kohli. I'm a Vice President and Chief Information Officer at Englewood Health in New Jersey. It's a prominent health system in northern New Jersey, right at the border of Manhattan. I oversee all of the IT, the biomedical engineering, the unified communications and telecom portfolio for the health system. And that is exactly the interesting thing about Englewood, which most people may not know. A lot of people think about Englewood as a fantastic community hospital where they come for good care. We are more than that. We have 150 locations in neighboring 5 counties where we bring care to our patients. This includes our specialty practices, general practices, hospital outpatient services. So it's really an integrated health system versus just one community hospital. And interesting thing about me, I would say, in addition to what I've been doing in IT for all these years, I'm also a certified diversity trainer and have done quite a few of diversity training in schools, colleges, professional organizations, including United Nations. So quite enjoy that and happy to do that again if there's an opportunity.
Inder, that's great. Awesome. And saving the best for last in terms of having a nurse, a clinician with us. So Mark, tell us a little bit about yourself, your organization.
Sure. So I'm Mark Perkins Carrillo. I am the Chief Nursing Informatics Officer for Moffitt Cancer Center. I've been with Moffitt for about 5 years. We are a comprehensive cancer center. And the thing that you may not know about us is we're a very young organization. We opened in 1986. So this year we'll be celebrating our 38th year. And the other portion of that is that we were actually founded as a result and perseverance of Henry Lee Moffitt. He was a former Speaker of the House of Representatives in Florida, and he advocated for us to be a comprehensive cancer center, and he founded us. So very, very awesome stuff. And then as for me, I know you won't be able to tell, but just from my looking at me, but I have been a nurse for over 30, right at 30 years now.
Wow, that's awesome. Thank you for the care that you give to patients. And we're also joined by another nurse, Joshua. Joshua, tell us a little bit about your organization, like one unique thing about your organization and one unique thing about yourself.
Yeah, sure. Hi, everybody. My name is Joshua Rosenthal. I am the Nursing Informatics Officer for Lehigh Valley Health Network here in Allentown, Pennsylvania. We are a 13 hospital health network here in Eastern Pennsylvania, soon to be growing to 14. We do have a new hospital that is actually opening its doors today, which is great and exciting news. One thing that I can share about our organization that I think is an interesting thing is we have actually been engaging in virtual care through a advanced ICU within the network for 20 years. We launched that program back in 2004. So we are, very excited about that. We have been working on expanding that within our network. One exciting thing about me, that's a tough one. I do have 3 daughters at home. I have 3 young daughters at home. It always poses an interesting home scenario. I'm very outnumbered there.
No, that's great. And are any of them, Joshua, are any of them Swifties?
Oh, they are all Swifties.
Yeah.
We all are. I'll admit it. When you listen to it for that long, you get into it as well.
Yeah, no, for sure. So what I want to do first, we're going to jump into sort of virtual care. What are we doing? What does it sort of mean within our particular organizations? Then we're going to dive deeper on the whole aspect of how do we do this in a cost neutral fashion and what our experiences have been doing that. So I'm going to start with you, Inder. Take us a little bit about your virtual care strategy. Do you have a strategy, and what are, 1 or 2 components of that strategy?
So I would say we have a strategy. I would not call it a virtual only care strategy. I think we have a care strategy which includes a merging of virtual and analog care. And I think it's self-explanatory what I mean by what virtual and analog care. But analog care is when you're actually seeking care within our 4 walls or one of our locations. So our strategy is to have this seamless merging, because all experiences start digitally. And at some point, after a virtual care, a lot of those encounters result in an analog care encounter. And my goal is, from a patient perspective, that all flows seamlessly. We are all focused on things which I think every health system is focused on: patient experience, interactivity, a nice user interface, seamless user interface. Where I'm actually adding extra focus is on training and support resources. Because we do have our patient helpline or help desk line where they call in for their MyChart issues, but that's where I need to expand it to, because we are rolling all of the digital care out to a population of all ages. We just need to be more cognizant of what their needs are. And one last piece I will say is part of my strategy is care coordination post-care, because that is where I think the true end-to-end care will happen for a patient, where post-virtual care, we have a follow-up from our clinical care, and our operations are aligned to help patients see through this process, both digitally and in person.
No, that's great. What about you, Mark? And we're actually going to ask this question of all the panelists just to get a foundation as we go in. But Mark, I would love to hear about how you look at virtual care and the strategy.
So, I'm very lucky. We have a senior director of virtual care here. Her name is Christine Nazo, and she is really focused on our virtual care platform, with one little exception, and we'll talk about that later, I'm sure. But the thing that I would say that's really awesome is having a dedicated team and not just looking at it as a technical aspect, because virtual care is more than just technical. Yeah. There's a lot of refinements to your workflows. There's how do you expand it, policy changes, and how do you integrate it across service lines. I mean, there's so much to virtual care. And if you don't look at it from a holistic value, then you implement something that is quite sure destined to fail.
Yeah.
I think that you really need that dedicated team.
Yeah, I'm going to come back to all of you probably on that point in terms of how you work with the clinical side. And for those of you who are CNIOs already, how do you sort of bridge the other direction? Because obviously it takes a lot of collaboration. So Brian, how about for all of you? How do you look at your strategy and maybe 1 or 2 pieces of that?
Yeah, I think the perspective that I can bring is that our organization is likely, maybe it's a little smaller than some of the other organizations. And so ours is, from a strategy perspective, very similar to what Inder said, is we seek to deliver care, and we can deliver that care multiple ways. Yeah. And part of that philosophy has to do with weaving the virtual care into normal operations. So we don't have it's all federated. All of our virtual care is delivered through normal, like for our clinics, for example. It's part of that practice versus having something that was set aside and different or dedicated. So I think that's the biggest thing, and then trying to make it as frictionless as possible and easy for patients and clinicians to interact with. So we were, everybody kind of saw the increase with COVID, but we've maintained a pretty good number of overall virtual care visits and volume since COVID. And again, our general philosophy is just to try to make it a part of each practice or service line.
Yeah, that makes total sense. And Brian, we are really happy you're part of this panel because we want to hear from all voices. So whether small or regional or a specific specialty, we're glad to have all of the voices here sharing their perspectives, and because that way we can relate to everyone in our audience. So I really appreciate what you're sharing. So we'll go to Joshua. What about you all in terms of strategy, maybe one or two aspects of that?
I really love what Brian said about weaving in the virtual care, because when it comes to strategy, for me, I have a firm belief that we need to integrate virtual care into the culture of our network. There are multiple caregivers who come in and out of a patient's room on a daily basis, and virtual care needs to be brought into our network and into our culture as no different from any other provider or clinician coming in and out of those doors. And that's what we are really looking to do within our network and within our strategy moving forward. We want it to be as easy as possible on our clinicians. We don't want to have to ask the floor nurses or the providers out on the floor to have to do anything extra. It's got to be integrated. It's got to work seamlessly, and it's got to be integrated into that culture so that our patients expect that virtual visit throughout their stay.
No, I love this, and I'm actually taking notes for myself. I think one of the common threads here that you all spoke about was just how it is just woven into the fabric of your organization in terms of how you operate, which is the ideal. But I want to ask specifically now, between the CNIOs and the CIOs on the panel, how do you work well with one another? So I will start, Joshua, with you. How do you work with, are you within the IT organization? And yes or no, how do you work with the IT or the tech part of the organization to make sure that you have that sort of collaboration?
Yeah, so we have a great program here. Our informatics department is integrated into our information technology department. We're actually known as IT&I, Information Technology and Informatics. I do sit on the CIO IT&I leadership panel. We have, consistent communication. We have an excellent CMIO as well. I think we all work together very well, and having that level of collaboration helps us to ensure that all of this stuff is done on a efficient level. Yes.
That's excellent. What about you, Brian? How do you work with your clinical colleagues, like as you develop this strategy?
Yeah, I don't want to oversimplify it, but I mean, everything's really about relationships, and and building relationships, everything in life and in work. And so I have a really good relationship on the inpatient side with our chief nursing officer, and she's very, very good understanding of the technology side of the role and where we can impact our patients' lives and on that side of the house. And then through our physician practice, it's mostly about working through. What's maybe somewhat unique about us is that we serve a huge geography. So we have patients to the west that probably will drive 2 hours or more to get to our facility. So if we can work together and work through our clinic managers and our clinical folks to be able to deliver care to those patients and maybe save them that drive, everybody wins. We also do a ton of outreach, which is a little bit different than the topic here, but where we're actually send clinicians out to them. But as it relates to a patient experience, if we can either bring the clinician to them or bring it to them digitally, that's a huge advantage in the rural part of the country where we are.
Yeah, for sure. I could see that. Mark, what about yourself? As a clinician, how do you work with your technical team?
So you want to bring a technical team over to your side, go out and tell them that they take care of more patients than a nurse ever can. You really emphasize the fact that IT, we couldn't do healthcare the way we do healthcare anymore if we didn't have IT, and that they touch more lives than I have the ability to touch with in my lifetime, taking care of 1 or 4 patients every single day. So it's amazing, and it's something that they don't really, sometimes they think of it as a burden. And I think this refocused them into seeing that it's not a burden and that they're actually delivering care.
Yeah. Yeah, profound. That was good. Inder, what about you? How do you work with your clinical counterparts?
So I like what Mark said, but I would say IT is the easy part here. And in my case, this is virtual care, or all of this is part of my digital transformation efforts. And IT is probably, or technology is 40% of it, if that. It's the operational alignment which is key. And for that reason, my senior director of digital transformation sits in operations. And that's her primary role, to really align the operations. And then we build a solution to seamlessly integrate the operations and our IT solutions. So that my way of delivering anything here is really an operational leader has to make a business case and a use case of a product. And then I bring in the shiny object they ask for rather than shiny object first. It is working well because we are really very use case and ROI driven organization. We're just not launching projects for the sake of it, but we have clearly defined metrics, clearly defined use cases before we build it. And we are, I would say I'm young in my journey here, only a couple of years. So far it seems to work well in terms of alignment.
Oh, that's great. So the first 15 minutes, we sort of did an introduction of our organizations and ourselves, and spent some time on strategy and how you collaborate with the clinical side and the technical side. And some of the key learnings that I picked up on is how IT is part of the care team, touches more lives as a result, definitely amplifies the clinical practice. It's all about the experience. You all talked about the experience for the patients. You all talked about collaboration, how important it was for you to cross collaborate. And then finally, that conceptually and culturally, everything is integrated. It's care, and there just happens to be some care that's virtual and some care that's in person. So super awesome. Now we're going to go a level deeper, and we really want to talk about this ROI. So how do you do, as the name of the webinar, how do you do the future of virtual care on a cost neutral basis? So I would love to hear from a couple of you on how you demonstrate ROI. So I'm going to start with Inder, but if any of the other of you are interested in answering this question as well, just let me know, and we'll go and pick up 1 or 2 more examples. So Inder, I'm going to start with you because you already mentioned it in your last answer. So how do you demonstrate the ROI of virtual care?
So I will repeat what I just said earlier. I work very closely with our operational leaders to build a compelling business case for any new initiative. And how do we build a case is, other than the alignment, it needs to have very tangible goals, whether it's improving access, whether it's enhancing patient experience. Is there a cost saving? Is there an ability to bring in new patients into the health system? All of those are part of our case. And in addition to that, when we build a case and when we launch a program, then we have a very clearly defined metrics which we monitor, whether it's a patient satisfaction score, whether it's a utilization of whatever technology or solution we have laid out. Are we realizing our cost savings? And clinical outcome, right? I mean, it's not really about, it could be either or. It's either a clinical outcome, cost saving, efficiency, or really an experience both for clinician and patient. Those are how we go about it. And really, in my organization, I am lucky that my executive leadership colleagues are fully aligned with it. And oftentimes they are the one who is executive sponsor and kind of hold everyone accountable to meeting those metrics in their department. And that is how we've been proceeding with it.
That's great. Brian, what about you all? Anything different in terms of how you might build your ROI or KPI case?
Yeah, I was thinking about kind of a philosophy, but also in a specific example. So when I say philosophy, I mean, I think that ROI and how it's determined is going to adjust based on organization and based on that organization's philosophy. So by that, I mean, how hard is it a hard ROI? Depending on the organization you're part of, do you really need to see an actual dollar for dollar ROI, or are you looking at things that could do other things? For example, patient satisfaction being at a certain level, and so I think a lot of that, it just involves knowing your organization, knowing the culture, and how to best frame the ROI for where you are. And one example that I would say that's probably the most tangible for us is we do some remote patient monitoring. And so when you look at readmissions and the cost of a readmission, that's a fairly it can be a fairly easy one as compared to other types of ROI. And if we get into virtual nursing as it relates to an inpatient environment, I think those things change too, depending on where you're at.
So, Mark, in the case of where you are, who would present the business case? So I imagine it's cross-collaborative, like we talked about developing a business case, but who goes and actually makes the pitch when it comes to, virtual nursing or, some of the virtual care we're talking about?
I would say, thank goodness, not me. And the reason I say that is because it is that hard thing about hard dollars versus soft dollars. Soft dollars are easy. You can find soft dollars with almost anything that you do, but the CFO doesn't love soft dollars, right? They want those hard dollars. And so for pitching it, that would fall back to our senior director of virtual care, with the exception of our virtual nursing program, which we're launching now. And then that would fall under our chief nursing officer, Dr. Kelly Gonzalvo. And it's a great partnership. I think I sit in a nice little section because I can step in and out, and especially as they're working through, well, where is the overlap?
Yeah.
Where is that line? And so it's an interesting situation, but I think it's a great carve out between the two, because nursing really needs some different stuff than a virtual visit, like a patient doctor visit.
Yeah, no, that's for sure. And Joshua, is it similar with you? Who might pitch when you have after you work together and you develop the ROI for virtual nursing or any other sort of virtual type care? Who's going before your governance process and being the main advocate?
Yeah, so here at LVHN we have a great steering committee set up that does look at those business cases prior to them going up to our executive vice presidents. And so when it comes to, virtual care, things like that, those business cases can come from my department. Usually that is done in a collaborative nature, though, with a number of people throughout the organization. When we put together our recent proposal for virtual nursing, we had collaboration from almost every area that you could think of, right? We had regulatory at the table, finance, nursing. We had risk management there. I mean, there were just countless people who really came together to create that business case in a collective way. And then we go on to that clinical steering committee and present that that business case, myself, our CNE, a number of different people who kind of bring that together. And then that committee is made up of a number of senior leadership members throughout the network, and we make those decisions in a collective manner as to what should go on.
No, that's great. And I'm just curious, just getting one more level deeper, and this is for anyone. I don't want to put any of you on the spot. So if there's something that you do, when I ask the question, just jump right in and let us know. And that is, okay, you've collaborated together. Someone, operations in some cases, sometimes IT, has pitched, has gone through your governance processes. Everything is lit. You go live. Is there some sort of measure that is taken at a later time to say, yes, we did achieve this, or no, we didn't, and here's some adjustments we need to make?
Absolutely. I think we've been tracking very closely on the metrics we originally set out to track. And the nature of digital transformation, the way we roll these projects out, lends itself to agile methodology and lends itself to allowing us to course correct. So yes, so I'll give an example. If we're running campaigns from last 6 months or so, we've been closely tracking how many of those campaign messages actually converted to a follow-up appointment, and then for how many of them actually kept that appointment and came in for the diagnostic or came in for the follow-up. So we've been tracking to that level. And when the original case was made, it was made with the presumption that X percentage. I think Mark said it correctly, right? Soft benefits are great, but CFOs don't like it. But I think we all have to balance the needs of clinical leaders and the financial leaders. So if we have some hard benefit that allows us to pay for the program, and the soft benefit is the gravy on top of it. And so we all try to do really, hard benefits as much as we can with an understanding that it's going to bring in the soft benefits and really eventually affect the patient care.
No, that's great. And just like Inder, you gave us a great example just now of virtual care and how you went through that planning process and tried to make it cost neutral. Can anyone else give us an example of some virtual care that you've done at your organization, and what were the KPIs and how did it work?
I think I will speak to that quickly. So we are currently undergoing a relatively large and quick expansion of our virtual nursing. And so when it came to virtual nursing, what we were really looking to do was to offload some of that work from our staff nurses. I think last year, we started to kick around that idea. What if staffing doesn't improve? What if the shortage doesn't start to ease and we don't get people back? What can we do to be able to help those nurses at the bedside? And virtual nursing very quickly became, the answer to that. And so when it comes to that ROI and looking at making those adjustments and moving forward, we really needed to focus on which areas of our network needed that assistance, being able to provide it to those bedside nurses, and then going back and having those conversations with those nurses to say, is this helpful? Is this making things better? What can we do different to provide the help? And I could assure you, we have had excellent responses from our bedside nurses. So far, they love the program. They love the help that it provides them. They are more than happy to have that assistance and to be able to unload some of that documentation burden to a virtual nurse.
Yeah, that's a great example. And Brian or Mark, we'll take one more example. Do either one of you have an example you'd like to share where you sort of went through this planning process and developed some ROIs and kicked off? And even if it didn't work as well as you thought, I'd just be interested in the process and what the example is.
Yeah, I think we have a great one that we did with KPIs. And so it was focused on clinic utilization, right? So the rooms being full all the time, and how do you get new patients in if you're seeing the existing patients all the time in those rooms? And so we've offset where the virtual care is performed. So from a physician's office instead of a clinic space. And so we're able to monitor how many more new patients we're able to see in those rooms by moving some of our existing patients to virtual care.
That's great. So what we just covered in this sort of deeper dive when it comes to ROI, you all shared some excellent areas where you look at KPIs and ROI. And if I missed something or something we didn't talk about, please bring it up. But we talked about improving access, improving throughput, improving experience for both the patient and the clinician. We talked about developing more business, right? Making your great services available to more individuals. We talked about clinical outcomes. We talked about readmissions and reducing readmission rates. We talked about where we could help with the workforce, with the struggles that we've had in nursing as an example. Are there any other areas where you all have done some work with virtual care in order to make these sort of improvements?
So I'll just talk from we are in the beginning stages of and have been kind of looking at what it look like for a virtual nursing program, but on a personal level, in some graduate work that I'm doing has been exactly what Josh talked about. Is when you look at the projected shortage of nurses, and it's a supply and demand issue, and how do we solve it? And again, having not just admittingly not actually implemented yet in our hospital as of yet, but when you look at a lot of it's nurse retention. So what does that nurse retention turn into? What does nurse satisfaction turn into? I curiously would love to know. I've spent some time investigating like nurse to patient ratio, and I know it's a sticky topic. because sometimes the ROI calculation has to take into account that you may be actually adding nurses and then calculating an ROI after that in terms of what does our retention look like? Can we decrease our falls? Can we increase patient satisfaction? So sometimes it's all those things kind of thrown in a pot and kind of seeing where it comes out.
Yeah, that's a good example. Yeah, anyone else?
If I may add, a slightly different perspective, so I'm in a very crowded northern New Jersey market. My patients have several options, and there are several health systems in a very small radius here. So for me and many other providers like me, I think it's almost like table stakes, because you do want to offer the convenience to the patient, because that's exactly what they're asking for. So in this case, it's not so much about virtual care as your strategy of reducing cost or augmenting your care. It's also exactly what the customer is demanding or the patient is demanding here. So I think that opportunity cost has to be taken into account for when we lay this thing out.
Yeah, that's a great point. That competitive analysis, right? And you want to be the first choice based on the ease to leverage your health system as well as the quality of those sort of things. So those are some great examples. All right, so we're going to move then a little bit into a technical area, just because I'm sure it's something you have to think about is how do you integrate the virtual care within the IT infrastructure? And so we already talked about how you integrate culturally and how you integrate it's just the practice of medicine. But also, how do you think about it when it comes to IT infrastructure? I mean, is that something that is still burdensome? So, Mark, Mark, we'll start with you. Is that sort of something that the IT struggles with a little bit, or how do you look at it when you think about virtual care and options?
Wow, you really touched on this one. This is really the biggest barrier to me is how do you get these technologies in place? The software is not cheap, the hardware is not cheap, and it's definitely not cheap to tear a room apart and have no patient in it while you're putting in technology. So it's a struggle, and it's one that we have to work through. But the alternative of having to bring equipment into a room with you to do virtual care or someone having to take it down is not a viable solution either. So
yeah, that's a good point. Inder, how about you? How do you look at that?
So I look at it from a perspective of first thing I need to do is reduce my technical debt if there's any in my environment. And that's really what I say is underlying baseline IT infrastructure, whether it's network, whether it's my virtual care environment, whether it's my VDI environment, network bandwidth, all of those things. The second important piece I would say is a very strong identity and access management, because I go back to this part of experience, both patient or prospective patient and clinician experience. And depending on how virtual programs are established, you're dealing with a consumer before they become your patient. So you need to have some way to identify them. You need to offer an ease of access and identification to consumer and then soon to be patient or patients. And then similarly, your clinicians may not have as strong bond as you have in today's environment. The way, again, you set up your virtual care environment, your clinicians may not be as closely aligned with you. And then again, you need to make a very easy way for them to access into your system and do their job. Interoperability is a third thing I would say, because again, your hope is everything is tied to your EMR. And that's how you're launching your virtual care, but that may not be the case. So now you're dealing with other operating systems, whether it's a file integration API, DICOM image exchange, something you need to think about. Again, the goal is all the information is merged seamlessly, because at some point, more than likely the patient who's seeking virtual care will come within your four walls for analog care, and all that information and experience should flow in. That's how I've been planning around my infrastructure.
Yeah, no, that's a really good way of doing it. We've gone over like 35 minutes on a panel and we haven't said the word AI.
I know.
But I do want to talk about emerging technologies, and you can talk about AI that are increasingly present in virtual care. So I will start with you, Brian. How do you balance the potential of AI or any emerging tech with the overall patient experience? How do you think about it?
Yeah, I think, and many are probably in the same boat, but again, given our size, these are going to be technologies that we take a look at that are embedded within our core partners. We're not going to go build our own, large, language model or anything like that. So we look at things that can still provide increased experience for both patient or provider. Things like ambient listening, those are really approachable things right now that can provide a good return and is using some of that technology on the back end. There's a lot of things out there that can do spatial awareness and can see how things are in a room, particularly a hospital room. I think there's a lot of interesting things there. So we still try to look at it through the lens of, like as we always have. And I always say that in technology, we're sort of, in a way, trying to make people lazy, right? So we're trying to allow people to do things that are easier, and then lazy is a negative word, but that more efficient. And so if that technology can do those things for us, great. I know there's emerging policy out there that can be. I think we need some regulation around artificial intelligence, but I don't want it to be so stifling that we inhibit innovation. So that remains to play itself out the next year or two, and how those things are governed. But I guess that's kind of how we take a look at it.
Yeah, no, super interesting. And Joshua, what about you all? How do you look at emerging technologies or AI?
Yeah, I obviously AI is a huge buzzword currently, right? And you can't go anywhere or listen to a presentation without hearing the word multiple times. And so you got to take that into consideration, right? Is it really something that is going to benefit the patient? Is it something that's going to benefit the staff? Are we doing our due diligence? Is it something that we could potentially do in-house? As Brian had made mention to, current partners, right? We always want to look at that. Is this something our EHR is going to be able to provide to us prior to going to another third-party software and bringing another third-party company into the network? I think that's really what it's all about. We have a artificial intelligence steering committee here. We kind of have to, because so many people are bringing forward multiple things and being able to vet those different requests and those different products that are out there. But at the end of the day, right, we want to do what's best for the patient, what's best for the clinician, to allow that clinician to take care of the patient. And so that's really what we do to allow to guide our AI stance moving forward.
Yeah, no, those are really good approaches. And I want to sort of wrap up that section and sort of head into the last part of our panel and talk a little bit about sort of what's exciting coming down the road. Could be AI or something else, and sort of give you all the last words. So this is going to be more of our sort of speed round. So I'm going to ask each of you the same question. We'll have 2 questions, and just sort of give us the top of your mind answer. But before we go there, I just want to summarize what we just covered. We were really talking about tech and how we integrate tech into, especially from a virtual care standpoint. And I think Inder did a nice job of summarizing in terms of how you have to look at identity, you have to look at interoperability, and tech debt. Like, what can you retire as a result of this, and make sure that you're not adding on or piling on onto that. And then we talked about how we would leverage current vendors, look at your current vendors, how are they doing, and what sort of things. And you're looking at the spatial recognition and ambient listening and different things like that. So very practical. The reason I'm summarizing is just making this super practical, because you all are sharing like really important things that you're doing in your organization successfully. And I know others are learning from it, as I am. And so it sort of makes it easy to say, yes, this is great. So here we go into our speed round. This will be a question for each of you. So given the rapidly evolving landscape, what emerging trends in technology or healthcare do you think are going to have the biggest impact, related to virtual care? So Inder, I'm going to start with you. What's that emerging technology that has you most excited?
I think you touched on it, that the ambient part is going to have impact. And I am looking at implementing ambient solution for clinician in the exam room, but I very easily see that transpose over in the virtual care environment, both for the clinician and patient. So an ability to have a conversation, ambient conversation, initially when you're seeking care, that's something I'm working on, which we used to call chatbot, now we call Gen AI-based virtual agents, omni-channel engagement. So I see that omni-channel is a key, and Gen AI-based is a key for a reason that nobody wants to talk to a rule-based chatbot anymore. So I see that as a profound effect. And if I may dream here, if you allow me, if I take it, because all the AI cases we are talking about right now, we all are planning to implement. I am with Brian, that we're looking at our existing vendors or partners who closely align. But in 5 to 10 years is where we will see really a big value add there. And that is where the predictive decision support modeling will come based on large language models. And that's really the key, because that so far what we are doing is synthesizing large amount of information, which is a rich information, our source of truth, and using that for efficiency. But that is where the next step of AI will come, where in 5 to 10 years, we can have that promise of personalized medicine. We can have promise of outcomes being affected at a point of care based on an intelligent large language model and synthesizing of all the data. I think that's what exciting for me.
Yeah, no,
yeah,
very exciting.
Mhm.
Mark, how about you?
So you should have called on me first, because ambient listening is the exact same one that I was going to go with. And I think of it from the nursing standpoint. Again, we have had so much time with vendors focusing on physician workflow and giving them ways of being able to chart and remove those clicks. And if you've ever looked at nursing documentation, it's way click heavier than a physician documentation. And so we need these ambient things, and they need to be hands-free. I see some vendors coming out and they're click a button here, take a phone out and record something. That's not what we need. We need something in the room that's listening. Hey, I started an IV, left forearm, 20 gauge, positive blood return, blah, blah, blah. And all of that queued up in our EHR, ready for the nurse to go back and validate, because we don't want to trust that there's not going to be some hallucinations with AI.
Yeah, excellent. Love it. Brian, how about for you?
You know, I'm just gonna, I think Mark combined a lot of thoughts that I was thinking about at the same time. I've done some research and graduate work, and I come from a family of nurses all over my family. And it's important to me that we figure out this nursing workforce issue. And it, like I said, you know, a lot of projections are pretty ominous. And so Mark kind of combined those things. Like, I'm most excited about virtual health in an inpatient setting, where we can allow a nurse to be able to do what they need to do, reduce the documentation burden, and increase satisfaction, and be able to hopefully solve some of the issues that the workforce challenges are going to present to us.
Totally agree. Joshua, yeah, I made it harder for you because, you know, all your colleagues had a lot of
you know, that's okay, because I'm not gonna beat around the bush and add anything new, because you know, ambient listening, any form of automation. But we need to get to automation, as all we do, you know, in my opinion, so often is ask clinicians, providers to do more. Let's start documenting this. So we got to start filling out this form and all of this type of stuff. We need to get to automation, ambient listening, you know, any type of automation that's going to do this without the clinician having to take action is going to be the way to go.
Very good. So we're going to end with one last lightning round question. I'm going to reverse the order. Joshua, I'm going to give you the first shot at this one. So you all are clearly very thoughtful leaders, and you're for mature organizations in terms of where you are in this virtual care journey, and realize that not everyone is there. And for sure, some people who are listening and listening to this panel are looking to learn. And I think so far, you all have shared so much. But if you were with them at the next Becker's conference and they asked you at a cocktail reception for 1 or 2 sentences, what should they focus on when it comes to a virtual care strategy? What should they do? You know, anything sort of general like that. What's one thing that you would impart to them that you would do if you were starting over? So Joshua, let's start with you.
Yeah, so if I'm going to go with 2 sentences, I'm going to say your first thing is to identify the need. find that area of the organization that needs the help the most. And then number two, start small. Start small, see what you can do, and grow, right? Go slow to grow fast, or to grow big, right? Go slow to grow big is my kind of way of looking at it.
Yeah, that's really good. Brian, what about yourself?
Yeah, pretty simple there. Again, like I talked about before, if you talk to 10 people and ask them about what their objectives and goals are in a virtual strategy, you're going to get 10 flavors of it. And it's because the organizations are different. So I'm just kind of doubling down on that again. Needs to be what's most important to your organization, and identify the need, as Josh said, but it has to be as it relates to your organization and how the culture will support that. And then really choose this is a easy one too, but choose a partner. Don't choose a vendor, choose a partner, somebody that can work through the bumps and bruises, because there'll be bumps and bruises. And if you have somebody who can work through those with you, I think you'll be successful.
Yeah, super, super good. Mark?
So I don't think Joshua could have said it any better. It's don't chase a product. Don't chase a vision. Figure out what the problem is that you're trying to solve, and then figure out what fits that solution. Don't go the other way. People, it amazes me the number of people who go to conference, and the next thing I know is I have 12 new requests on all these solutions that they need. And it's all going to all save their life. And I can look at our 900 products that we have in IT and tell you that all of those did not solve every problem that we needed. So figuring out that problem first.
Very good. And Inder, we will end with you. How would you counsel your protege?
So I would take a slightly different take here, and that's more for a health system to consider, because virtual care essentially means also convenience, and convenience is the number one thing our patients and to-be patients and the next generation of patients are looking for. But what does it mean? It also means that that very strong bond between a doctor and patient will loosen a bit with a virtual care. So which we need to be prepared for. So it's no longer Dr. Smith and John Doe, it's more X health system taking care of a patient, and your interaction is with Englewood Health versus just the doctor. So I think with virtual care is going to expand, no doubt about it. And what will also happen is that bond will loosen a bit. And it's more about trust with the health system and then the physician.
Yeah, very good. So if I were to summarize all things you just said, Inder, plus choose a partner. You don't have to make it up on your own. Choose a partner, someone that you trust. Align with your strategic priorities of the organization. Identify the need, kind of goes back to strategic priorities. Where are the pain points? Start small. That's really wise. Start small, go slow to grow, or go slow to grow fast. And those are all like super, important things. So if you're watching and just embarking on your journey and thinking about, where to go with virtual care and how do you do it in a zero cost environment, those are really important fundamentals. So we just spent almost the last hour talking about virtual care on a cost neutral basis. We started off hearing great stories about your organizations and what you've been doing and how you do it in terms of your strategy and how you're organized to do it. And then we spent most time on the ROI. What are the KPIs? What are the sort of things that you all look at and how you do it, and sort of your structure for making sure there's accountability and those things get done. And then we dived a little bit into the tech part of it and how you ensure the seamless integration. And then you all shared, great ideas about how to get started, or even if you're in the middle of it, but struggling, just, how to maybe course correct. So awesome for all of you sharing. If you had one word as we end, so you're just limited now to one word, when it comes to virtual care and strategy, anything that we talked about, what would that one word be? And with that, we're going to end. So we're going to mix it up. We're going to start with Mark and then head to Brian. So Mark, what's your one word?
Possibilities.
Love it. Brian?
Innovation.
Love it. Joshua?
Exciting.
And Inder?
Convenience.
Love it. Yeah, this has been so great. I learned so much. I hope everyone watching learned half as much as I did. And thank you again panelists, and thank you for, and I think it was Mark or Joshua, one of you brought it up in the very beginning. What you all do, especially with tech and accelerating, the virtual care and reaching and scaling, you're saving lives every day. So thank you for everything that you all do and being part of the panel.
Thank you for having us.
All right, that concludes this panel on the future of virtual care on a cost-neutral basis.
That is all the time we have for today. I want to thank all of our panelists for an excellent discussion and Ed Marks for moderating, as well as AvaSure for sponsoring today's webinar.